All right, we will go ahead and get started in the interest of time here. Um, Part of me, so I wanted this to be a little bit of an open forum, so we want some sort of feedback too. We'll be sending stuff out via survey, but more of just kind of how can we improve, what would be useful, right, to add or subtract. Um, so that's really partly what I want to do with this type of end of year session, but also, I wanted to just kind of include a recap because it has been a busy year, right? This was sort of our schedule of what we've done throughout the year, starting in April and then obviously ending here in December. Um, there's there's talks given by Dr. Jeff Burns, myself, and Michelle Needham. So all of us are on to available for any questions, but I can help direct a lot of the questions. So if we kind of go through things, we actually first technically started with normal versus abnormal aging, right? And that was that's a major issue, not just for primary care docs, but even for us memory specialists, right? What is that line between an early mild cognitive impairment and normal aging? And so, first it kind of makes sense of focusing on who we should be asking, right? So when we look at the high risk population, it's those 65 and older. That's when we're starting to get around the 10% risk, prevalence of mild cognitive impairment. And you can basically double these numbers across age ranges if you include dementia into the MCI group. So really the Medicare wellness visits probably make the most sense, but obviously there's a lot that you're trying to cover in a Medicare annual wellness visit. So even something as simple as a mini cog does seem to have better sensitivity even than something like an MMSE. So just keep that in mind, a very short test there. Honestly, what we really recommend, what's even better, is something like an 88, which is basically 8 questions that you can even send to a family member as long as the patient is okay with that. And we get better information, obviously, if there are true early memory problems going on. But then if there are concerns raised with either of those, then that's where performing a better screening, using a better screening tool like the Montreal Cognitive Assessment, the SLUMS, or what we use, which is the short test of mental status. And then if there's any question kind of even with that, that's where detailed neuropsychologic testing really helps out. And we sort of have this algorithm, right, where if a patient is recognizing a change from baseline, which subjective cognitive impairment is a real thing, that's what we see a lot of, um, then is there agreement, right, with some sort of informant or at least a positive 88 in those questionnaires, right? And then is there impairment on formal screening? So maybe it's through your bedside screening tests, or maybe someone has really high education and you're not quite sure if this bedside screening test is going to tap into any early changes. That's where the formal neuropsych testing really comes into play. And so if the answer is that they do not have any abnormalities on detailed testing, then that really fits better with what we call subjective cognitive impairment. Most of the time, that is likely normal aging, but in someone with a strong family history or a lot of concerns, scheduling a serial cognitive evaluation 12 to 18 months down the road just to make sure there's no change makes a lot of sense. If there is abnormalities on cognitive testing, then our question is really whether there is daily functional impairment or not. And if the answer to that is no, then that's mild cognitive impairment. If the answer to that is yes, then that's more in the lines with what we call dementia. And when we kind of moved on to, okay, we've identified mild cognitive impairment, well, what are the necessary steps in working that up? Because there's actually a lot of reversible or treatable causes or contributors to mild cognitive impairment. Most of the time, these labs are checked, the thyroid and normal blood tests at yearly visits, but oftentimes B12 is missed. So we shouldn't be the ones detecting B12 deficiency in a memory clinic. So make sure you're checking that. Um, Hearing and visual loss. I think really the hearing loss is a really big one. It's one of the big risk factors for developing dementia. So screening for that in patients at risk for it, and treating it when it's there. Medications can be a big one, right? Especially anticholinergics. So there's a whole laundry list of anticholinergics. You can look at an anticholinergic burden scale calculator to see if your patient's med lists kind of add up to a concerning amount of anticholinergics. But the daily use and cumulative use of these are associated with increased odds of dementia. Um, Untreated sleep apnea is a really big one. So this is often overlooked, but treatment of sleep apnea, especially in early stages of cognitive impairment, can reduce the rate of dementia over a 3-year period. So that's important to be as far as a treatable risk factor. And then we always have to think about stress and anxiety, depression. How much are those are tied into the diagnosis itself, right? And how much are exacerbating it versus how much are just part of the disease. Um, when we look at why, so why do we do this? We actually have a whole film on this now. So we have a YouTube link of it of it's 37-minute film that Michelle Needham's put together for kind of why an early diagnosis matters. But in summary, right, it does promote autonomy, especially in a time point when patients can still, express their wishes for what they want. Um, later as the disease progresses, it improves outcomes, especially for both caregivers and patients, when we look at delaying transitions to long-term care, it helps in removing some of those medicines. Why remove any of these medicines if we don't know if they have early cognitive impairment, right? That's at least puts a block in a reminder to, hey, let's evaluate for these contributors. And then we also are able to start engaging in research studies that are specifically focused on early stage disease, right? That's probably where we can make the most impact. If we're diagnosing at dementia and even later stages of dementia, there's been billions of neurons lost, right? We cannot bring those back. Any of our interventional research, work is gonna have a bigger impact at earlier stages. We moved on to just differentiating the most common types of dementias. And here I had this table to at least sort of help just kind of, what are those dividing lines that we look at, right? So in dementia, we're really getting impairment on not just cognitive testing, but also on activities of daily living, right? That's sort of our definition and differentiating it from that mild cognitive impairment. We have sort of this umbrella idea, right? So dementia is really an umbrella term with Alzheimer's disease being the most common, about 60 to 65% of what we see. Most of the time, the symptoms are consistent with memory impairment, repeating questions, forgetting appointments. And then we usually see shrinkage of the memory structures here in the hippocampus that fit along with a short-term memory problem. For vascular disease, this is usually in someone that has had a history of strokes or at least has severe white matter disease on their MRI scan, which looks more like this on an MRI. So that's another reason why imaging can be important. For Lewy body disease, which is really the second most common cause, we look for at least 2 out of 4 criteria for this, right? So 2 out of 4 of these features. And then we usually see a more normal looking MRI, whereas like a glucose PET scan may look drastically different than the MRI. And it's usually the back part of the brain that's involved. Then in front of temporal dementia, we're really looking for a lot of behavioral personality changes, especially early on in the disease. And then if the left side is involved, it can be more prominent language symptoms. And this is more rare, about 5 to 10% of dementia cases, but a PET scan is well equipped to detect, which pattern we're seeing, so we can be more confident about our diagnosis. We talked about managing and preventing delirium in older adults. So why did we talk about that? It's an issue that needs more awareness, and it's extremely common in older adults. So some studies, it's up to 50% of individuals over age 65 admitted to the hospital, and it's preventable in the a large amount of cases. It's a risk factor for neurodegenerative diseases, at least from a progression standpoint, right? So I've sort of likened it to this. It's a cognitive stress test when someone undergoes one of these stressors. And if somebody's diagnosed with MCI and they develop multiple episodes of delirium, they're going to develop dementia faster in the vast majority of cases. And so this is where I also kind of brought up this idea as dementia is really more of a multiple hit hypothesis, right? Where we know that amyloid plaques are building up in someone's brain for many years before they actually get symptoms. And that disrupts brain networks, right? That disrupts some sort of downstream brain efficiency. We know in alpha-synuclein diseases, which is Parkinson's and Lewy body disease, that there are often prodromal symptoms happening well before We see cognitive impairment and dementia, and these can include constipation, acting out dreams, autonomic symptoms. If we look at genetic cases of neurodegenerative diseases and follow them over time, knowing that they have a mutation that's going to cause the disease at some point, we see changes in their brain networks well before we see clear symptom onset. So there are things happening under the surface that we're just not aware of in the vast majority of times. And when you have these pathologies building up in the brain, you're going to get a disruption of blood-brain barrier, and that's going to potentially be a vulnerable system, right? And so any sort of inciting event that might be neuroinflammatory is going to reach the brain easier, and that's sort of that stressor, right? That cognitive stress test that we're now applying in someone that has lowered cognitive reserve. And so delirium may be that canary in the coal mine. So if you have a patient that's having kind of multiple periods of delirium when they get admitted to the hospital, that should be a red flag, right? That they might need more workup. When we discussed Alzheimer's disease, we used the title "It's Not Always Memory," right? This is the classic, short-term memory presentation of amnestic difficulties, just like we talked about earlier. And then we'll usually see difficulties on delayed recall testing, and they'll often have shrinkage of the memory structures. But Alzheimer's disease is not always a pure memory disorder. So we have all these different phenotypes that we look at, right? This one here is a classic memory pattern of just like typical Alzheimer's along the lateral temporal lobe. These on the left are glucose PET scans, and on the right are tau PET scans. And you can really appreciate how where the tau is depositing in the brain drives one, symptoms, but also the changes we see on the glucose PET scan. Language is another presentation of Alzheimer's. We call that logopenic primary progressive aphasia. We have visual spatial presentations that are more in line with posterior cortical atrophy. And then we have this one on the bottom right, this executive progressive dysexecutive syndrome, which is actually very common in young onset patients. So if you see someone under age 65, they actually are more likely to have this subtype than the more typical Alzheimer's disease. Dr. Burns talked about preventing dementia. So we often get this question of, I want to keep my brain healthy. What can I do? We have a whole LEAP program designed around this, right? This has multiple, sorry, get back to this. This has multiple basically ways to sign up. So there's kind of self-paced video modules, and there's also live classes and courses that people can join. And there's access through our website. When we look at the risk factors for dementia, at least ones that might be controllable, right? It accounts for about 40% of dementia, and we can look at early life risk factors, which are really education. We see the delay of onset of dementia in folks that have high education by up to 7 years. And then hearing loss, really midlife and later life. But hearing loss is one of those large ones that was a bit surprising seeing come out, how large it was. But there's a lot of these that are factored into social isolation, vascular risk factors, right? And so at an individual level, but also at a policy level, we need to do better about pushing for these changes and these risk factors that we can control. When we talk about Lewy body disease, I sort of group together both dementia with Lewy bodies and Parkinson's disease dementia. Really, Lewy body dementia is that umbrella term that encompasses both of those. And so when you kind of lump those together, that is the second most common cause of dementia. So we call that the second, diagnosis and treating the second most common cause. When we think about diagnosing someone, especially with the dementia, label, right? That it's obviously got to interfere with their daily activities. But then we look for at least 2 out of 4 of these criteria. They do not have to have all 4. And I sort of group them in this. This is how we usually see them present. So oftentimes acting out dreams precedes symptoms. Sometimes it doesn't, but a lot of times it does. Cognitive fluctuations, these kind of spacing out episodes, these drastic fluctuations of cognition where they can be normal and all of a sudden totally not normal within an hour later, sometimes minute to minute. That's sort of the second thing we usually see. And that's where we'll start to see impairment on cognitive testing, especially in certain domains. And then the visual hallucinations usually come later. and they're supposed to be well formed, complex visions, usually people and animals. That's the typical presentation. What happens years before hallucinations? We'll hear stories of feelings of presence, like someone's in the room, someone's following them while they're walking. There's sort of like this shoulder presence. Um, we'll have paranoid delusions occurring well before hallucinations in many cases too. So there's a spectrum here that we're often missing if we're just focusing on the sort of criteria of well-formed hallucinations. And then Parkinsonism, really any amount of these, you don't have to have all these, but just one. So slow movements, troubles with balance. I sort of rate these in how I typically see them too. So balance is usually the major first issue in Parkinsonism with Lewy body patients. Whereas like someone that presents with typical Parkinson's may present with just a tremor initially, and it's sort of almost opposite. For helping detect Lewy body disease, we recommend this Lewy body composite risk score. It's a quick 10 questions that you can ask if you at least have that suspicion. The first 4 ask more about motor symptoms, right? And then the last 6 ask more about non-motor symptoms. And if you're scoring at least 3 on here, checking a couple of these yes boxes and you're scoring 3, especially if you're kind of, well, I'm kind of between Alzheimer's disease, dementia, and Lewy body dementia. A score over 3 is pretty highly correlated with Lewy body pathology at autopsy. So having this in your toolkit is important. Michelle Needens led a talk on the power of multidisciplinary team, right? This is the direction that things are going. This is just the natural course of complex diseases. We're going to have multidisciplinary teams. And then there are at least reimbursement models that are centered around this. So being aware of these and staying up to date with them is important. We want to start to integrate health education, and we're currently working with around 100 or slightly over 100 primary care providers across the state and region in collaborative practice models. So that includes early detection with good tools, right, to detect things early, social work integration. So at a time of diagnosis, getting that education and disease education and framework in place rather than the sort of crisis model of what we currently have. Oh my gosh, we need help now. We need to be thinking about those and planning for them and detecting things earlier. So this was a nice map that Michelle Needens put together. This is a couple months old now, but really kind of where are we accessing throughout the state. So these are cognitive care network providers here in blue, some pending sites, and then some adjunct sites. And so really we want to be able to expand this. What we also need though is we need more community leaders within local areas, right? So that they can be more flexible with what this community needs. So we need community leaders rather than us trying to it's the spoke and wheel model, right? But we have to have more spokes throughout the state. And so partnering with folks that are interested is one of our goals, right? With everything that we're doing. And so this also, there's considerations for the future, right? What if we had, more partnerships where maybe it's just we're dealing with this certain behavior associated with dementia, right? What are some of the tools that you guys would look into? What are some of the things we need to look into? Maybe it's tele-specialist visits, especially for folks that can't make it to our center. So these are things that we're obviously wanting to expand upon in the future. We talked about primary progressive aphasias, really just language disorders in general. And so to diagnose someone with this, they basically have to present with early language symptoms. It's not the same as someone that has clear dementia and then develops language issues. It's a clinical syndrome. It's not specific to one pathology. We see it in Alzheimer's disease as well as frontotemporal disease. And we can usually group folks based on certain features. But when we make a diagnosis, then what do, right? So if we had someone with balance problems, we would recommend physical therapy to try to help prevent falls. And too often we're not referring folks to speech and language pathologists. And so we saw in a study that 78% of folks diagnosed with primary progressive aphasia did not have access to speech and language therapy. So the benefits of this is, one, it helps with strategies and communication aids, right? And then it also helps with disease education, especially for primary docs that wouldn't be able to necessarily tell them what this is, right, or what the timeline looks like. Incorporating experts in this is important. We looked at different medications, right? So this is the timeline of all the approved medications with obviously the lecanemab being the newest kid on the block. When we look at cholinesterase inhibitors, though, they're often not prescribed, especially early on, and they probably do have a better role. We don't prescribe memantine on its own very often at all. It's usually more of an adjunct agent. And those drugs are okay for Alzheimer's. They work much better for Lewy body disease, but we use them in both. And then there's these new monoclonal antibodies that we now at least have in our toolbox. I had this sort of summary slide of should my patient be on an acetylcholinesterase inhibitor. So that includes obviously donepezil, galantamine, and rivastigmine. And if you've got a patient with Lewy body disease, whether they have dementia or earlier stages, the answer is absolutely yes. I can't be more emphatic about that. When we talk about Alzheimer's dementia, the answer is yes there. We see even better improvement, especially in our young onset folks with working memory and dysexecutive variants. Both the short-term and long-term data supports use in Alzheimer's disease. For mild cognitive impairment, it is technically off-label, but it doesn't really make any sense if you're certain that their mild cognitive impairment is due to Alzheimer's disease to wait until dementia. We use this very often when we've kind of ruled out those other contributors of cognitive impairment. For vascular disease, I say probably not. However, right, the co-pathology is very common. And so if there's any hint that there could be Lewy body and Alzheimer's co-pathology, we usually will still give it a try. And if they get no benefit, we can take them off. We do not use it in front of temporal disease. It can often worsen behavioral symptoms because they're not deficient in acetylcholine. Some tips, right? So these are things that I see in practice every day. So I know the pill box says to give it at nighttime, and I know that's the default way that it's ordered in almost every health system, but it really makes sense to have this drug peaking during the daytime when they're using their brain. So we recommend giving it in the morning, but with a protein meal to help reduce GI side effects. We started at a low dose, we increase over 4 weeks. This is pretty common. However, what we'll often see is, well, they had GI side effects, so we stopped it. No, let's try, if they did well at 5, right, let's try splitting the dose, right? Let's try dividing it so it's not a peak effect from a pharmacokinetic standpoint. And if they still have issue, well, and sometimes we'll even go higher. So I've got, especially my Lewy body patients that have constipation at baseline, they can tolerate much higher doses. But we'll never give those in one dose. We usually split it 10 milligrams with breakfast and dinner. The problems with nighttime dosing, so we'll often hear issues with insomnia and nightmares, and cognition all of a sudden is worse when I started it. Well, it's because they're not sleeping well, right? And then REM sleep behavior disorder can get much worse on these drugs if given at nighttime for our Lewy body patients. For galantamine, I usually will utilize the extended release version for that because that has a lower GI side effect rate than donepezil. But a patch is a nice alternative, especially for folks that get pretty significant GI side effects. We had a number of slides on the new monoclonal antibody drugs. I think it's important for takeaways, right, is that these drugs are not benign. They are not a cure either. And there's a lot of uncertainty of what happens long term with these drugs, right? So all we can really say is that there is a statistically significant slowing, about 30% over 18 months. And some people, and there's improved downstream biomarkers. So there's some signals that we're making a potential impact on disease pathophysiology. However, right, there's a lot of risk here. One being safety, right? The other being cost. There's a lot of burden in the number of tests that we need to do, the number of MRI scans for surveillance of these risks, right? And so this drug is not for everyone, but it is at least an option for some, right? And hopefully we'll learn more about long-term benefits of it as we gather more data. For treating behavioral symptoms, so still the first line is the drugs we just mentioned, the cholinesterase inhibitors. But for depression, anxiety, especially anxiety, SSRIs with with anxiolytic properties like sertraline and escitalopram are our preferred drugs of choice. For agitation, especially if it's anxiety-driven, trazodone at low doses, like, 25 milligrams, even 12.5 milligrams. For paranoia, atypical neuroleptics, more in the quetiapine and clozapine category rather than dopaminergic blocking agents. There are newly approved drugs, this brexpiprazole. However, it's pretty expensive because it was just approved. Aripiprazole is a similar acting atypical antipsychotic. For hallucinations, really acetylcholinesterase inhibitors is the first line. It can actually make hallucinations go away in some patients. So that's really our first line treatment for these. Sometimes we don't need to treat them. But then atypical neuroleptics, the newest kid on the block is pimavanserin, and that can work in a certain number of individuals, but might need some sort of cost reduction program to be feasible. So the summary on that of kind of do's and don'ts, right? If you have an acute change in behavioral symptoms, right, it really behooves you to look for what could be causing it, because we don't typically see that in someone with a slowly progressive neurodegenerative disease unless, right, they have one of those inciting events that's causing a cognitive stress test, right? So infection, insomnia, we've had some patients, they go for like a week of barely sleeping and then they get delirious, right? Certain medications that were added that they might have side effects to. Informing caregivers and involving them in these symptoms early on is important. Optimizing our medications that we do have available, but then really the non-pharmacologic approaches can make a big impact, much more than medications in some cases. In anything you start, especially in this patient population, you need to start low and go slowly up. So I don't need to, yeah, so we'll oftentimes see things started at too high of a doses, and then side effects really trump any benefits. And then, so yeah, I had one patient, they were given one dose of oxybutynin and they had delirium for 3 days. That's an outlier, but just goes to show you that they can be very sensitive to anticholinergics, especially if that system is low, and benzodiazepines. So tips for disclosing diagnosis, right? We first kind of talked about the importance of an accurate diagnosis. Most people want to know why they're having memory symptoms, right? So they come to my clinic to try to help understand what's going on, right? And in many cases, this is closure for an explanation of the symptoms they've been seeing, right? Especially for the family. And oftentimes we can't move forward with planning if we don't know what we're facing, right? So having that diagnosis is important. But according to the Alzheimer's Association, right, that actual diagnosis occurs less than 50% of the time. So oftentimes patients are on medications like donepezil, but they aren't certain why, right? Or at least their family is not sure why. So in trying to, and then the other big thing, right, is what happens after a diagnosis, right? So oftentimes families feel lost of exactly where to go next. And so that's been a limitation of, sometimes we don't tell someone a diagnosis because we don't know what to do, right? That's where starting to implement, right, these chronic care models, and including social workers and other team members that have dementia expertise to create this sort of collaborative system, right? Because we really need to improve disease education and symptom recognition and early symptom detection, right? Rather than all of a sudden getting a phone call that they've called the cops because of paranoia and now they're in the ED and they're getting drugs that are probably causing things to worsen. And we sort of see this spiral that we often see in patients with dementia. When we talk about sleep, it's extremely important. So I have a very low threshold to check sleep apnea in our clinic. I find sleep apnea very commonly in our patient population. There's been a study that's looked into this as well. And Alzheimer's disease does have this bidirectional effect with sleep apnea. And so one study found that especially patients in that dementia range, mild to moderate dementia, 90% of them had sleep apnea. 22% was mild sleep apnea, 29% was moderate, but the majority were severe. They probably had it for years, right? There was a window that we could have probably intervened on brain health early on. When we look at folks with mild cognitive impairment and risk of dementia, whether they're using their CPAP or not, we see an odds ratio, like a reduction basically in risk in both all-cause dementia and in Alzheimer's dementia in those that are using the CPAP machine versus not. We talked about different strategies for insomnia. So oftentimes patients are taking over-the-counter medications that we're not even aware of. Many of those have anticholinergic effects that could be impairing memory and contributing to confusion. When we look at the first line agents, right, there's the melatonin, there's trazodone, and then there's SSRIs for that mind racing cause and mirtazapine that we utilize. Jeff had a talk on, oh yeah, I moved those, sorry. We had the driving discussion, right? That's kind of the elephant in the room. It's actually probably the hardest discussion we have, even more so than a diagnosis in many times, just because of the independence factor. It is good to at least hand your family members that are with the patient, right, some sort of red flag warning signs to be looking out for. So I'll often print this out for them to take with them just to, and I recommend, hey, ride with them, right? I don't, that's oftentimes the best indicator of whether they're safe to be driving or not. When we have those discussions, really appealing to responsibility and liability is important. You know, I get concerned based on certain testing scores, right? But oftentimes, when we're dealing with progressive diseases, it's not a matter of if, but when. And on-the-road driving evaluations are the kind of gold standard, but we really have to improve the accessibility of these to a good evaluation, but also the cost, right? That's a major issue. But tapping into that liability, most patients can understand that. And many have sort of a, well, I wouldn't want to hurt anyone as well. But there are lots of patients that don't have good insight into their symptoms. And so trying different strategies is important. Michelle introduced her neuropsychiatric symptoms guidebook, right? It's extremely useful tool, especially for both providers and patients that are dealing with behavioral symptoms. And there's an online PDF link as well as hard copies that are available. And then Dr. Burns also discussed connecting your patients with research, right? So one big thing is My Alliance. This is just a simple newsletter. So if patients don't want to dip their toes into the research arena just yet, but they might want to learn more about it, we have a whole newsletter that comes out. Hey, what are we doing? We even have tips and strategies for brain health, but it has all sorts of resources to access information on research studies that are going on. And it has more up-to-date information as far as which ones are currently enrolling. And then there's obviously ways to refer directly to our research studies rather than our outpatient clinic, because those are two different things. So there's internal ways through the KU Health System for providers, but also for community providers, we have access to those as well. So I'm going to stop there. I'm already over time, but I know I want to check the chat box. Got a couple of different questions here. Yeah, so Angie, Richmond, yeah, so Angie, I would say, so Parkinson's, right, would be bradykinesia plus any of the other three. Parkinsonism, ideally bradykinesia is the sort of, that's the Queen's criteria for sure, but especially with Lewy body disease, we often see patients with postural instability well before we see other symptoms. And so I think when we look at the Lewy body criteria, I would even take the postural instability as a major concerning sign. And let's see. So I read recently that after a diagnosis of dementia, there's a significant increase in suicidal behaviors, especially for those younger, and highest in 30 days. So so it is statistically significantly higher, especially in younger onset folks. I might have Michelle weigh in on that too, but oftentimes, so we have had that come up just a handful of times in the clinic, but having resources, especially with our social work team, is important. And I think that navigating that is something that is very difficult, right? But for the that should not make it to where we don't want to give a diagnosis, right? Because 99 0.9% of folks are here. They're trying to figure out what's going on, right? But there are the certain subset of patients where we have to be very mindful of that. And you are correct that the younger onset folks, especially those that are high functioning, otherwise, they can have an increased risk of suicide. Michelle, are you on? Let me just double check.
Yes.
Oh, there you go.
Yes, and I would just add it's not as much suicidal behaviors, but it's suicidal thoughts, and that's what is extremely high post diagnosis. And Dr. Townley is correct. It makes no commentary on whether a diagnosis should be given or not. Of course, it should, but it makes profound commentary on the need for support services afterwards. People think of these multidisciplinary teams more as task driven, and we have to think of them more as emotional driven. There is grief and changes and fear and absence of knowledge in the community. People think they're going to crash. People think they're going to be a burden immediately. And so it is critical to have that dialogue, and it can be remitted reasonably quickly with appropriate support post-diagnosis.
Yeah, that's well put. Does anyone have any input on or things that you'd want to see for next year? Can put in the chat or wait, and we'll obviously be surveying the folks that have been attending these. We may be changing venues a little bit of where these things live after recording, but that's all to be determined as well. All right, well, we are already over time, so if there's no other immediate questions, we'll obviously upload this as well, and then we'll be in touch when we start to think about planning for 2024. So, all right, take care, everyone.